Um, I made two videos, but um, I took them down. So I'm going to speak more neutrally, and I'm not going to reply to the account. They have people posing as nurses on here who are clearly not nurses. They have this one account, Lou in Alaska, saying she's a RN. Right away, you know she's not an RN if you actually are RN. So she describes a scenario where she has a dementia patient who has a known infection and they start to sundown. Because this is not a real nurse, she doesn't know that's called sundowning. She describes it as being more confused and abusive. Um, she describes how she uses the nonverbal pain scale used for detecting pain in dementia to give Tylenol, and how she deals with good humor his behaviors, puts on the TV distract, sits with him all night, then gives report to the next shift that he's in pain. That's his issue. So, yeah, here's your sign off. Right away. Oh yeah, she also describes calling the doctor for an order to crush pain medicine at night. that part sent me. Now I'm actually an RN. I graduated in 2008. I was the valedictorian of my class. I graduated first in my class. I'm a BSN. I worked bedside 14 years. I was a manager many of those years. Yeah, that's not actual reality. So here's what's going on. Like, when you're a nurse, you're trained to think in terms of prioritization of needs. So, to a person who has no medical training, you might think the priority is pain. And corporations sold this. They sold pain as the sixth vital sign. You may not remember. This is what led to the fentanyl crisis because corporations were trying to elevate. See, trained medical professionals know pain is not the priority. It's a concern, but it's not the priority. But they try to create this cultural thing like pain is so important. You have to make sure you're getting medicated for pain. Why? They want to sell OxyContin, right? Now, if you're actually medically trained, there are a lot of times where pain management has to take a slightly lower priority. Examples, this could be altered mental status. If a more pressing immediate need, life or death, then managing the pain will be secondary to those things, right? Pain is like in medicine, pain's a concern, but it can often be subordinate to other things. Like if you have a patient who's altered, like say, let me give you an example. Say you had a patient who hit his head and you're waiting on a CT scan and he's like, ow, my head. You do not want to give that guy Dilaudid. Why? Because the signs of a brain bleed are somnolence. So one of the first things that happens is you want to go to sleep. And you go to sleep and you never wake up. So you want to avoid using, like if you, in certain conditions, you don't want to use any depressants, of which narcotics are, that could lower consciousness and prevent monitoring. Agitated patients who have altered mental status or dementia, very commonly these patients have atypical reactions to a lot of medications that affect the CNS, right? So what's a common thing to happen? You have an agitated patient and you might give them a benzo and they actually get worse. Or you give them a pain pill and they while out. I'm just saying there's lots of things to consider here. So I'm trying to explain how managing pain is something you do in context or general duties of a nurse of prioritizing needs, right? So if you're actually a real world nurse and you have received, you're on shift and you got this guy, you know he has dementia, it's confirmed, and it's now nighttime and he's starting to act up, your first two thoughts are going to, and you know he has an infection, especially, the first two thoughts are going to be this: safety is the priority, and also considering that this could be a change in stability and his known infection is worsening and he's becoming delirious, right? So those are going to be your first two things. Pain is also a consideration, but you're going to have to balance managing pain with making his mental status worse, leading to worse behaviors that could cause a safety issue. Yeah, so that's your actual two priorities: safety and is this medical? Like, as in, is this an infection, delirium? There's lots of things that could be going wrong. He could be constipated. He could be this. He could be that. Like so many things. But you get clues like, do you know his baseline behaviors? Does he do this every single night? Then that's probably sundowning. He's suddenly worse than usual. And if he has an infection, you're going to be looking there. Even if he doesn't have an infection, he's suddenly worse than usual. You're going to be thinking like, did he poop? Let's get it. You're not going to call the doctor for orders to crush him. That just that sent me because I'm just imagining. Imagine if you called any doctor at like 12 a.m. like, doctor, can I crush medicine? They'd just be like looking at you on the phone like, get away from here. Like, when you admit patients, there's generally a template of orders like, I can do this, I can do that, and can crush medication when not able to take is like on there. So no, you wouldn't call it an order to crush medicine. That just wouldn't, especially not at night. But you might call in the situation like, oh, he really acting up. Let me take his vital signs. Okay, he got like a low grade, and especially in elderly, if the temp's a little bit high, because usually elderly people it's more common to have a slightly lower temperature. Like this could be something. Let me call up for labs. Let me get a CBC, CMP, ESR, CRP, UACNS, and CXR. Those are your general workup to see if there's an infection, right? Chest, piss, blood counts, chemistry, and markers of inflammation because they go up in an infection, CRP and ESR. You might call for that, but you're not going to call for an order to crush meds. Like, it all depends on the case. Like, is this something he does every single night? Most likely a sundowning. Nurses don't give PRNs for sundowning. Now, if it's real bad, you might, but like, generally, the way you handle a patient who sundowns is you get a consult with a geriatric psychiatrist. Sometimes in a pinch, if it's real bad, you can call the attending and they could prescribe something pretty small that is used for that, like Ativan or occasionally a microdose Seroquel, something like that. But it's really like the geriatric psych will take over and be like, here's some 7.5 of mirtazapine with valproic acid sprinkles, 125. We'll try that twice a day. They'll work their way up to a pattern where it's like, okay, he goes to bed now and he's eating and everything's okay. And he'll be monitored by a geriatric psychiatrist, right? If it's pain, again, like Tylenol really is not that great at managing pain, first of all. And if an infection's causing pain, they'll likely be on stuff to help manage that. But speaking of the nurse, you're trained to think in an order of hierarchy of needs, and in that case, the two biggest issues are safety, because he could fall, and is this medical? Is this known infection getting worse? You don't want to just use chemical restraints to make them go to sleep. And a lot of times pain meds act that way, and benzos. Also, this nurse acts as if it would be an inappropriate and sign of a bad nurse if she delegated safety to a CNA. No, that is standard. Few RNs, many CNAs. It takes 4 years after high school to be a nurse. There are more CNAs, and they do care, like assisting with eating, helping getting dressed, helping to the bathroom. They tell the nurse stuff going on that they see because a lot of CNAs develop some skills, and they're like, you got to take a look at him. He don't look good. You're like, okay. And watching patients to keep them safe, transferring patients with a Hoyer lift, things like this, CNAs will do. Nurses are more the assessors and planners. So like, a CNA duty would be to watch a patient who's agitated. A nursing duty would come and assess the situation and make a plan. Like, okay, we're going to do Q1 hour monitoring. If we don't have enough people for a sitter, which is very commonly, everyone's going to rotate for an hour with this dude because he's super dangerous to himself. Yeah, if you want a world where RNs are sitting one-on-one with your dad with sundowning, pay some taxes. I mean, it still wouldn't be enough because there's never going to be the healthcare infrastructure for that. But it's given that the people liking this tweet are like, yeah, fucking them Democrats want want people to pay taxes. That's like the kind of lane they're in. It's like you believe that it would be inappropriate nursing action to delegate one-on-one observation of a patient sundowning to a CNA. Like that's a sign of a bad, callous nurse. And like you just know it's fake because it's like the only medical thing they know is pain. So they're like, he's in pain. It's like I'm just laughing because I'm imagining how many people are fooled by this. It's like this is what's going on. Like people who really have no skills and no use to society are destroying it. And the billionaires are teaming up with them. No, it's not an appropriate nursing practice for an RN to delegate observation to a CNA. And it's not the nursing priority, pain. It's one of many priorities. And your biggest priorities there are this guy can't fall and this guy could be sick. Like we know he got an infection, but it could be getting worse. And you know, this is delirium. And you might call for labs in that case. I mean, depends on what's going on. Like if they have a temp. If they have like a temp, then you might call for labs at night, or if not, you might just wait till the morning if the vitals are stable but they're acting up, and then like let them know like you need orders, like have the doctor check them out. Yeah, and I'm not saying pain ain't an issue. It is, but I'm just saying that's not how Aaron thinks. And it all depends on what the baseline is, what you're going to try to investigate. Like, is this something they do every single night? And it's probably sundowning. Yeah. And also the insinuation that most nurses are callous toward dementia people with behaviors is not true. Like, the vast majority of nurses are used to it. And they don't react to old people being mean. Which is why, like, all these comments that are like, wait till you get old, nurses are going to treat you so bad. Like, like, you learn to see so much shit as a nurse. Like, it makes you, like, that's the domain of a 19-year-old who's never had problems. Like, reacting to stupid shit. Seeing their mom put them on a diet is trauma. Like, in order to get nurses to react, it's got to be something like, did you know he's a chomo and went to prison for it? Or like, did you know he killed his whole family? Then they might rumor about that and feel away. But again, that all depends on the setting. Like if you were a prison nurse, that'd probably be old hat to you by then, and just be like, yeah, okay, another one. Yeah, that's not a real nurse. And that's not how nurses think. And their number one concern is like, don't fall on the floor and break your hip, because if you're old, you won't be able to handle anesthesia and make it out alive for your ORIF. And yeah, is this person sick? Like, are they? I know they have an infection, but even if they don't, like, let's take some vitals. Are they okay? Pain is like next. Like, yeah, pain is not the sixth vital sign. That got us fetty, and corporations made that up. Because in any medically trained person, it's life or death and then comfort, right? It's not that you don't care. It's that sometimes treating comfort has medical secondary effects, like being a heroin addict, or in the case of people like, oh, I fell my head. Ow, you bitch, you fucking bitch. Ow. Like a demented person might say after they fell down. As a nurse, you're going to say, I'm not giving you anything. You're going to stay awake. I mean, I'll give you a cold compress. I'll do stuff that's not going to lower your consciousness. But right now, you being awake supersedes the throbbing head you have. It just does, because of the fact you could fall asleep and never wake up. Right? So yeah, these are things medically trained people know. But like, if you're on X, you're like, defund the Democrats. You're like, yeah, I went to the nursing home and there was no nurse sitting with my dad. They had a CNA sit with us because they don't give shit. And I said, give him medicine to make him better. And the nurse is just like, your dad has dementia. There's no medicine for it. Giving him a medicine to like make him go to sleep is called a chemical restraint. We have him on consult with the geriatric psych, and they're trying to get a good routine with his meds where it's like an acceptable balance of managing behaviors but not overly sedating him so he doesn't eat and get sick and stuff. And this is something he does every night. It's not because we don't care, it's because there's no medicine for dementia. And we are trying, like I said, he's on psych consult and they're trying to find a good regimen that works for him. But I can't give him a medicine to make him stop doing this. That's not really, is it is, you fucking demon crat. It's like, yeah, just saying.